Let's move on to incretin-based therapies. Now, before I talk about the actual drugs, I want to talk about what incretins are. So let's imagine you have an orange and you decide to eat it and it goes into your stomach. Well, your stomach and your small bowel will release something called incretins. These incretins act on the pancreas in two ways, not one way, but two ways. First, it will act on the beta cells to actually increase the amount of insulin that you release into the body. This decreases sugar levels. The other action is that it works on alpha cells to decrease glucagon secretion and once again decrease sugar levels. Now, this is an important distinction between these drugs and other drugs because the amount of alpha activity with the incretins is much greater than the other medications or the other hormones. A DPP-4 is kind of like Pac-Man because it goes in and eats the incretins. So it's kind of our built-in mechanism to get rid of incretins once we no longer need them. A DPP-4 inhibitor gets rid of Pac-Man, right? So DPP-4 inhibitor now allows more incretins to do its job for a longer time. So there's a couple of advantages to this particular method. First, it's a very natural way of affecting your systems because you're taking advantage of internal systems to bring down the sugar rather than, say, artificially stimulating a cell to secrete insulin. You're using incretins, which are a naturally produced hormone, and you're letting them do their job for a longer time. The other advantage is that the DPP-4 inhibitors almost have no hypoglycemic risk. Now, a GLP-1 analog is an analog of incretin. So DPP-4 inhibitors and GLP-1 analogs are working through the incretin pathway. They're slightly different in terms of where they're acting on the pathway, but they both have the same effects. Net effect, improved glucose control. Now let's just take a look at the various drugs in each of the drug class. If you notice and if you pay attention, the DPP-4 inhibitors end in gliptin. So there's saxagliptin, sitagliptin, linagliptin, and so on. When you take a look at the GLP-1 analogs, they end in tide. So there's exenatide, liraglutide, etc., etc. Now, the other thing I want to mention is that the GLP-1 analogs are injections, whereas the DPP-4 inhibitors are pills. Now, the DPP-4 inhibitors have a neutral weight effect, and they're very, very well tolerated. They reduce the hemoglobin A1C by about 0.9% if you take all the trials and put them together. I should mention, though, that if you have an A1C that is 10.5, the amount of reduction that you'll get from your DPP-4 inhibitor is going to be up to 2%. If your A1C is 7.5, the amount of reduction you're going to get is probably 0.5%. So your amount of reduction is proportional to where you're starting. So the higher your starting A1C, the more A1C reduction you're going to get. Generally speaking, these are once-a-day tablets. There are actually subcutaneous forms that are given once a week, however. They are rarely associated with pancreatitis, but the risk is there. You can get occasional nasopharyngitis with these medications. In terms of the GLP-1 analogs, these are the drugs that end in TIDE, they may actually cause weight loss. So there was one study that looked at one of the GLP-1 analogs and showed that 30% of their patients lost 3 kilograms and they kept it off. It reduces hemoglobin A1C anywhere from between 0.9% and 1.5%. So as an average, I just put down 1.3%. Remember, as I said before, these are injections, and these medications are actually increased with more GI symptoms than the DPP-4 inhibitors. Be aware that these medications can be associated with a very aggressive form of pancreatitis, so monitor your patients closely when you start them on these medications.